Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you, Brian. Thanks, everyone, for having me. I'm going to share a case that I thought raised some important questions regarding hepatitis B immunity, and I'm focusing on vaccine-induced immunity for the sake of, I have limits in terms of time. It's a good opportunity to discuss what we've learned and what is coming up. So I have no financial conflicts of interest or disclosures. So this was a 45-year-old man with HIV on abacavir, lamivudine, and dolutegravir with a past medical history that was notable for multiple sexually transmitted infections, including latent syphilis. He had a history of chronic kidney disease with a baseline creatinine of about 1.5 that was thought to be due to tenofovir DF nephrotoxicity in the past. So he got admitted to the hospital this past fall with profuse diarrhea and dizziness and ultimately got diagnosed with shigellosis and incidentally was found on admission to have an ALT of 279 and an AST of 166. Medicine team sent hepatitis B serologies, and it came back with a positive Hep B surface antigen and a viral level of 31 million. So I changed a few details, not sort of critically clinical details to protect his identity. The HBV was very high, clearly breaking through the lamivudine he was on. And unfortunately, an anti-Hep B core IgM antibody was not sent, so we don't know for sure how acute this was, but I suspect the patient had chronic infection at this point when we discovered this, because when you look back at his ALT and ASTs, he had elevation in the 100 to 200 range dating back to 2018. So the reason why this case was unexpected becomes clearer when you look back on his history. He was considered immune for all intents and purposes. He was diagnosed with HIV in April 2003 and had completed hepatitis A and B immunizations at the STD clinic. And those are the date ranges for the doses. And had in May 2003, when he established care in Madison, Hep B surface antibody that was 17, which is above the threshold where we would consider him immune. So the surface antibody is key here because unlike many of our other vaccines, including the COVID-19 vaccine, I'll say, we actually do have an established correlate for immune protection when it comes to hepatitis B in the surface antibody. And by most assays, the threshold by which we consider it protective is above 10, or currently our assay, the threshold is 12. So I thought this case would be a good launching point because if you look further at his serologies, he happened to have gotten additional serologies after that point when he established care, you could see that his surface antibody began to wane over the course of the following sort of decade or so. And by the time we diagnosed him, the surface antibody was not detectable and his surface antigen was reactive. So yeah, this was a case of unexpected new hepatitis B infection. And I thought it would be a good launching point to talk about HBV immunity in people with HIV. It raises important questions about the durability of vaccine response and seroprotection, especially in an era where we are looking towards ART simplification and NRTI sparing. So this was a recent case report brought to my attention by Jihan Budak as another reminder that HBV can happen at any time in patients we presume to be protected. This was a report of a 31-year-old man with HIV who was enrolled in the FLAIR trial of cabotegravir and rilpivirine, had gotten oral induction and a lead-in followed by monthly injections. He was found to be Hep B susceptible, didn't have any of the serum markers before enrollment, and therefore received Hep B immunization with the standard 3-dose recombinant hepatitis B vaccine. He was treated for multiple STIs in the intervening time, including rectal chlamydia, syphilis, and shigellosis. 9 months into the study, he was found to have acquired acute hepatitis B. His ALT was first noted as being elevated in the 160s and then later peaked to 594. His Hep B surface antigen came back positive. Core IgM was positive as well, and his viral level is shown here. The investigators tested his archived serum about 5 months after the completion of his vaccine series, and he had not developed seroprotective immunity. This, by the way, wasn't checked. I think someone forgot to check, and it was only afterwards, retrospectively, that they were able to determine that the vaccine hadn't worked. So it turns out that our initial patient was not unique. There have actually been some additional cases of unexpected Hep B, a total of 3, including this one in Madison Clinic the past year. They all share in common that they're newly Hep B surface antigen positive, so they had a documented negative previously. They all had a history of absent or low anti-Hep B surface antibody titer, so 10 or 12 or less. And none of them had tenofovir, either alafenamide or diazoxyl fumarate in their ART regimen. 2 of these patients were core antibody negative and had previously been vaccinated. One was an isolated core antibody and showed evidence of prior exposure. So why is all of this worthy of concern? Just a reminder that having chronic hepatitis B has major clinical implications for our patient population. Unlike hepatitis C, we don't have a cure for Hep B. And like hepatitis C, it is an important cause of liver-related morbidity and mortality in people with HIV who are much more likely to succumb to chronic infection when exposed and more likely to experience liver-related complications compared to their HIV or Hep B mono-infected counterparts. I think these cases also upend a lot of our assumptions around Hep B seroprotection in people with HIV, especially those who have been vaccinated. And I want to go over those assumptions. One of the assumptions comes from data in immunocompetent adults who have gotten vaccinated. So we know that waning surface antibody titers is a phenomenon. This is well described that, people who get immunized, they don't always maintain the same level of Hep B surface antibody titer and that these levels wane. But these folks have generally been considered immune. And this is based on data. This is an example of one of these larger longitudinal studies from the Alaska Native cohort. They had looked 22 years after people had gotten kind of the standard 3-dose recombinant vaccine series. It turns out of the almost 500 patients that they evaluated, the majority of them actually still had protective levels. And those they did not, they did a booster dose and evaluated their response. And it turns out that when you look at the people who had maintained their surface antibody levels and the ones that had responded, had developed an anamnestic response and developed brisk return of detectable Hep B surface antibody, the protection demonstrated at the end of 22 years was still approaching 90%. And there's healthcare worker studies that have also shown that these surface antibody levels can wane in, the 10 to 30 year time frame and fall below the level considered protective in about 25% of cases. But most of these patients develop a rapid and robust response to a booster vaccine. So these are really the data and the reason why Hep B booster vaccination has generally not been considered necessary. But what's fascinating to me is that we have extrapolated this idea that waning surface antibody levels still means people are immune to those with HIV, when in fact, this may very well not be the case. So we know for a fact that the high immunogenicity we've observed in immunocompetent individuals with Hep B vaccine is not seen in those with HIV, with vaccine response ranges in the order of 25 to 65%, depending on the case series. This was a case series that we published from the Madison Clinic over a decade ago. And one of the striking things we found is that nadir CD4 count and HIV viremia were 2 key independent predictors of lack of vaccine response, so that those who had a low nadir, less than 100, and who were still viremic, had a less than 15% chance of responding compared to 75% of those who were higher and had viral suppression. This is data from the US military HIV natural history study. One of the advantages of this cohort is that it is not only among the largest prospective cohorts with regular HIV screening, and the reason why this is relevant is you can reasonably be certain that the date of diagnosis is not too far from their actual date of infection. So this was about 1,800 participants, over 1,800 participants. 23% got their Hep B vaccine before their HIV diagnosis, about 2/3 before and after, and the remaining 41% had gotten immunized after HIV diagnosis. And you can see right away that timing mattered greatly. So the folks who were most likely to have reached protective immunity were those who really got immunized before they seroconverted. So the longitudinal data from the Alaskan Native study that I mentioned, we don't actually have that same quality of longitudinal data for people with HIV. But this is one of the smaller series that kind of attempted to look at kind of long-term persistence of immunity. This is data from an Italian cohort of 119 patients with HIV who completed a standard 3-dose vaccine series and got evaluated several years later for persistence of protective immunity as defined by surface antibody titer greater than 10. And what was clear is that the longer the time interval from vaccination, the higher the risk of loss of seroprotection. And it's notable how this percentage really dropped by the time you reach just 7 years. And unlike the Alaskan cohort or the healthcare worker studies, the majority of this HIV cohort did not maintain their seroprotective antibody levels. So we have tried a lot of different strategies to improve Hep B vaccine immunogenicity in people with HIV. And I'm not going to go into those in detail. Suffice it to say that nothing has really stuck or really been compelling enough to change clinical practice guidelines. But I do want to talk about adjuvants because this is where the story may change. So what is an adjuvant? Well, an adjuvant is basically an additive to the vaccine. We've all had vaccine on our minds, so pardon me for those of you who are already quite familiar with what adjuvants do. But it basically can increase the immune response by improving the presentation of the antigen. And so it's enhancing both inflammatory and innate immune response. So the older recombinant are standard, the ones that we have been using for all these many years. The recombinant Hep B vaccine uses an aluminum salt as an adjuvant. And what has come around is a newer adjuvant, a synthetic oligonucleotide called CpG, or I think that stands for cytosine phosphoguanosine. It has the CpG motif, acts as an agonist for toll-like receptor 9. And what's distinct about this is that these oligonucleotides directly activate these peripheral dendritic cells and B cells, whereas the alum adjuvant really just kind of in a non-specific way stimulates dendritic cells. The CpG actually has a broader base of stimulation and creates basically a foundation on which antigen-specific adaptive immunity is based, so that there is generation of both humoral and cellular adaptive immune responses. So what's the data on CpG? Well, the CpG vaccine actually did get FDA approved in 2017, but does not yet have a label for people with HIV. The main registration trial showed that with 2 doses a month apart, it stimulated a very robust and early seroprotective response compared to the standard Engerix recombinant vaccine. And it performed very well compared to the standard vaccine in people who have historically not responded as well, such as those with diabetes, obesity, or tobacco use. So what data do we have so far in people with HIV? We don't yet have the large-scale trial safety and efficacy data yet, but what early data we have seen is encouraging. This study is actually from Canada that looked at an early progenitor of what was to become the CpG Hep B vaccine that's now commercially licensed. This trial examined long-term seroprotective responses in 38 HIV-infected patients who were randomized 1-to-1 to receive either the recombinant Hep B vaccine with or without the CpG adjuvant. And then surface antibody titers were measured every 6 months for 5 years. And you could see that it looks like the curves split off pretty well and that there is a higher maintenance of seroprotective titers in these patients out to 5 years. So again, this is a small pilot study. It's really kind of a proof of concept, but this, stay tuned for more information about this. In the meantime, I think we just have to do generally better about vaccine delivery. Vaccines don't work unless we give it. So the CDC published these data a few years ago evaluating how HIV care clinics across the US are performing in terms of Hep B vaccine delivery, and the answer was actually quite poorly. And this included Ryan White-funded clinics. So yeah, it turns out the delivery came just under 10% for people who are Hep B susceptible. The other notable finding was actually that among those who were susceptible, almost 8% seroconverted or showed evidence of natural infection during the time of observation, which is again another stark reminder that Hep B is actively circulating and we need to protect patients from this. So I always try to end my ECHO talks with some take-home lessons. These are just some of my thoughts in the context of this particular case. One is Hep B is out there actively circulating. Vaccinate early. And ideally, I think many of us really see our patients after they've already gotten their HIV diagnosis. But if you have like an active MSM or someone on PrEP, like that's the time you really want to Hep B vaccinate them. And I don't delay vaccination in high-risk individuals who have multiple sex partners or inject drugs. Always remember to check an anti-surface antibody titer 1 to 3 months after the last dose. We need to see if it works and to follow through for those who did not seroconvert. I won't go into that in too much detail. The revaccination strategy may actually, in fact, change with the CpG vaccine, that data that comes out. Other reminder is actually, I think we should think about screening those with new and unexplained ALT and AST elevation for Hep B surface antigen as well as Hep C antibody, regardless of prior what we thought of as immune or vaccination status, because of what we're seeing, especially if their vaccine was remote and a number of years ago. The other thing I want to point out is that I think clinicians have sometimes relied on antiretroviral therapy as being a shield against hepatitis B, because it turns out, some of these nucleotide analogs we use are actually also active against Hep B. But it is not a fail-safe protection against Hep B. Tenofovir may be more protective, but in our case, remember, this patient still developed Hep B on lamivudine. And then just a reminder that if you're thinking about switching someone to an NRTI or tenofovir sparing regimen, to please consider all of the above, as well as the risk of Hep B reactivation in chronically infected individuals. So stay tuned for this trial, which I think will be here in Seattle. It's going to start enrolling this month, or has already started enrolling. I also wanted to make a quick plug for our UW Hepatitis B online website. The QR code is there for you guys. We have a module on Hep B immunization written up by one of our senior fellows and acting instructors, Maria Corcoran. That's excellent and can serve as a good review. And I will end here and maybe take a few questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.